This is.
And the posterior is known as the neuro. Same thing. Yeah, think of it like this. Anterior for the A, adeno. Okay, the neuro is just the other one, the posterior one. A for anterior, so adeno hypophysis, and the neuro hypophysis. Those are the other terms that they use to describe the lobes of the pituitary gland. All right, let's talk about acromegaly. We're only gonna, in the exam, folks, we're only gonna be discussing, for this first exam, A and P, diagnostic tests, and these disorders of the pituitary gland. Okay, so essentially only the hormones that are released from the pituitary gland are gonna be discussed in the first exam. Okay? Yes?
We're going to be taking 2 exams for this chapter, or just one?
It's three exams. It's 2 exams for it's 2 exams. It's this one, then it's the actual glands disorders, and the last one is diabetes. Okay, so the last one is diabetes. It's a test within itself. You had a question. Pardon me? I'm not sure. I'm here today, and I'm here next week, and then after that, Miss Lee comes here. So I don't think Miss Tapper's going to be coming back. Okay. All right, guys. Acromegaly, real quick. What does megaly mean? Large, right? So when it comes to acromegaly, it's overproduction of the growth hormone, and we talked about growth hormone just pretty much regulates how you grow. But it's in the adults. That's what acromegaly is, and that's the main difference between acromegaly and something called gigantism. You folks are gigantism. You guys watch UFC? You guys see Andre Bigfoot Silva or whatever his name is? He has a huge. You guys should Google him later. He has a huge chin, and his hands are huge, and his feet are huge. What ends up happening with patients with acromegaly is that all organs start growing as well, and eventually the body can't keep up, and they end up dying of some type of other disorder, complications. But acromegaly is overproduction of growth hormone in the adults. Okay, and we'll talk about gigantism in a bit. It's idiopathic, meaning we don't know why, hyperplasia or excessive growth of the anterior pituitary gland. It could be also a tumor at the pituitary gland, and changes are irreversible. So really know what acromegaly is. Okay, it's really important you guys know that first statement right there. It's growth hormone, excessive growth hormone, but it's in the adult patient. So it happens later in life. It can happen in the 20s, but usually we're going to see it in the 30s, 40s, 50s. Actually, 40s and 50s is where we're usually going to see it. Okay? The onset at least. Pardon me? Yes, yeah, How many people in the class? 1, 2, 3, 4, 5, 6, 7, 8, 9.
I think there's like 32.
29 in here, right now. Who's missing? Where's Celia? Absent. That's the only person I noticed absent. Is that it? Alright, may I switch the slide? It's on your PowerPoint too. But if you guys want to copy it down, I get it. Because the more you write it down, the more you see it, the better. Alright, so clinical manifestations for acromegaly, which only happens in the adult. Enlargement of the cranium and lower jaw. And these are very specific, folks. So they're going to have a bulging forehead, okay, an enlarged lower jaw. Jaw is the lower portion anyway. Separation and malocclusion of teeth. So essentially, they can't really bite and close the gap. So when they smell that, okay, there'll be no gap. Okay, yeah, it's the muscles, and the actual jaw that's protruding. So the actual closure of the jaw can't actually occur adequately. Okay, or sometimes it's at an angle and things like that. So it just really depends on where the hypertrophy is occurring, but they can't really bite down adequately. Bulging forehead, a bulbous nose, very common. Thick lips and large tongue, very common. Generalized coarsening of the facial features. So coarsening, think of it like leathery, it gets really tough. Essentially that's what it's talking about. I don't know why I took off my glasses. Okay. Enlarged hands and feet, and enlarged heart, liver, and spleen. And essentially, folks, look, this is what gets you at the end. You folks remember Andre the Giant, or heard of Andre the Giant wrestling, WWF? Back when it was WWF, not WWE. That's what he died of. He died of a heart attack. Okay, because his heart was so big, his heart enlarged, and it couldn't pretty much keep up. Now, don't think of it as a big heart. Oh, you have a super heart. No, it's like hypertrophy of the valves of the different chambers, so it can't really pump effectively. So the patient eventually had heart failure. So not a heart attack, sorry, heart failure. And the same thing happens with the liver and the spleen. So the patient can have a lot of different complications. Again, what age group does this happen in? Or just
40, 50.
Later in life, adult. Okay, good. The patient will have different enlarged appendages, but they're going to be weakened. That's why that guy Silva that fights, Bigfoot Silva, he has a glass jaw. Falls real quick. So you'll have muscle weakness, hypertrophy of the joints with pain and stiffness. Males, impotence. Females, deepened voice, increased facial hair. Amenorrhea. What's amenorrhea? The cessation or the absence of the menstrual period. Okay. Cessation is like it stopped. Yeah. Partial or complete blindness with pressure on the optic nerve due to the tumor, because again, where's this tumor or where's the hypertrophy going on? The pituitary gland, the anterior or the adenohypophysis. Adenohypophysis. And then the patient will also manifest severe headaches. Any questions so far with the manifestations of acromegaly and who gets it? Okay. The picture on page 489 pretty much shows what a patient looked like in her younger years with the glasses, and then later on. You see that nose? Very classic bulbous nose.
So it's the same person?
Yeah, it's the same person. Mind you, it doesn't happen from one day to the other. It's a slow progression as it continues to develop. And here's the illustration. What was that?
She just looks aged.
Yeah.
Her nose is bigger.
Yeah, her nose is bigger. And her face is longer.
It's a close-up. It's a
Her
mugshot.
lips look bigger.
Enlarged lips, bulbous nose. Okay. The forehead you really can't notice. And yeah, this wouldn't be one of the better illustrations of acromegaly. But essentially this is what ends up happening. She looks, her face looks a little more robust, don't you guys think?
There's the close-up.
That is true, that is true. I have a better PowerPoint. I can't find my flash drive because I thought I was going to tell you. But anyway, I have better pictures though. I'll bring it next week, I promise. Medical management. So before we even talk about the medications, what do you think those medications do? Yeah, they either reduce the size of the pituitary gland, or they actually stunt the secretion of the particular hormone that's being released. So we have something called Parlodel, Sandostatin, and we give analgesics as well, in particular for the joint pain. What type of analgesics do you think we're going to give for joint pain? Okay, anti-inflammatory. Which type? NSAIDs. What do you give it with? Food. Always with food, because you get too many NSAIDs, the patient will develop some type of ulcer. Okay. Cryosurgery. That's actually going inside, pretty much shrinking the adenohypophysis. Transfernodal removal of the tissue. See, I had a really good picture for this one. Essentially, we go into the nose, okay, with a long tube, and we go inside and we remove the actual portion of the tumor. Okay. Proton beam therapy. I'm thinking proton pump inhibitors. Proton beam therapy is some form of radiation. And when it comes to the diet, of course, since the patient can't really grind or close their mouth well, you want to give them a soft diet, something that's easy for them to digest.
Don't change it.
I won't change it. It's on your PowerPoint. Just look. Is that real? The door's messed up. That was my best. May I switch to slide, folks? All right, let's talk about gigantism. This was very similar. Overproduction of growth hormone caused by hyperplasia of the anterior pituitary gland, same stuff, but it occurs in a child before closure of the epiphyses. What is that? When do the okay, let me talk about the epiphyses real quick. The epiphyses, folks, are the portions of the bone of a long bone. We have an epiphyseal plate. Which is from here to there and from here to there. Okay, I don't know if you guys remember this from musculoskeletal. And essentially when a bone grows, it goes from this to that. But what's actually growing is this section right here that eventually becomes this. At what age do people typically stop growing? It varies by like 2 or 3 years for males and females, but essentially by the 20s, right? Late teens, early 20s. By 21, a male stops growing. Okay. In particular, the end of puberty, the end of the onset of puberty is when the epiphyseal plates stop actually growing. That's all it's talking about, okay, guys? Gigantism is in the child. That's when it happens. So that's the main difference between acromegaly and gigantism. Adult onset for acromegaly and a child onset for gigantism. Alright. Great height for these patients. Increased muscle and visceral development, increased weight, normal body proportions, but they have weakness. Medical management includes surgical removal of tumors, same thing, irradiation of the anterior pituitary gland. Yes.
Gigantism?
Yes.
How many inches a year would they grow?
I wouldn't be able to give you an exact number, but it's not like they get super huge, like 8 feet tall. It's more like these patients. What can I give you an example of? This guy gigantism. Yao Ming. You guys seen Yao Ming?
Yes.
The basketball player. So for him, yeah, he's like 7 feet tall. I don't know how tall he is. I can't give you a specific inch, but I can give you a percentage. Okay, if an individual grows throughout the puberty, because in the onset of puberty is when growth hormone is more being produced, right? So when an average teen, you grow, let's say, an average of 6% a year through the peak of puberty. For people with gigantism, they're growing like at a 23%. Okay, so but what's unfortunate, it's not so much in like their vertebral column either. Some of them it is. So you see them have very robust features. Okay, very seldomly do they get really tall like Yao Ming, things like that. But it's a little bit different because they're more proportioned. Does that make sense? Yes.
Yeah, if the child is diagnosed with gigantism, does he get eventually acromegaly when he gets older?
No, because this particular growth spurt is occurring in adulthood, so it's just considered gigantism. The bulbous nose and all those other features, they won't be really apparent because when you're young, what happens to your skin? It's nice and intact, right? So that's the main difference why during an adult the nose gets bulbous, the forehead gets really big, because the skin texture is also really different. Okay? So if somebody develops acromegaly, it's just because they develop this later on in life. If somebody develops, it's all the same thing, guys. It's excessive production of growth hormone by the adenohypophysis. Okay, the anterior pituitary gland. But with this one, it's during childhood, before puberty is over, and then with acromegaly, it's on the onset of an adult, after the epiphyseal plates have closed already. Does that make sense? Dwarfism. Deficiency in growth hormone, usually idiopathic, meaning we don't know why it happens. Some cases attributed to autosomal recessive traits. Autosomal recessive traits essentially means that you get it from both parents. Okay. Autosomal recessive trait, meaning both parents have this recessive trait, and then both of them pass this particular gene on to you, and now you have it. So who's got dwarfism that you guys know? In the media, I'm sure.
It's a TV show.
Yeah.
Little people.
You guys watch that? It's not even entertaining. How about Wee Man?
Wee Man, yeah.
Yeah, Wee Man. Oh, he's not. He's just really short. Danny, what's his name? Danny DeVito, yeah.
Oh, he's not a little person?
No, he's, well, compared to Arnold, yeah, he's tiny. But no.
His wife too.
The patient has abnormally short height, normal body proportions, appear younger than age, dental problems due to underdeveloped jaws, and a delayed sexual development for these patients. Okay, so just know that dwarfism, guys, is the opposite of your hyperplasia, yeah, of the gigantism, acromegaly.
So what do they die of?
They usually don't have any complications like that. What do they die of? Yeah, the patient, since it's a decrease in growth hormone, their organs aren't really affected in such a way that, like gigantism, the body usually acclimates, meaning they kind of make up for it. They can actually live a pretty normal
So they have
life.
regular size hearts, regular size organs?
In proportion to them, yes.
Don't they have like a bone problem?
A lot of them have hip issues, yeah. A lot of them have hip issues. That's right. And that's not only because they're short, it's because the world that we live in is also accommodated for people like us. And that's probably not something that you guys can really appreciate. Like walking up the stairs, I mean, it's no big deal for me, right? But if you think about a little kid walking up the stairs, they have to go like this. And my daughter's doing that all the time. I'm like, hurry up. So same thing with Wee Man, right? So when they live in a world that's made for people that are of average height, they have to utilize their bodies in such a way that's a little different. It puts more strain on them, and eventually they develop joint disorders. Okay.
I have friends that are real people.
Really?
And their house is everything love custom.
You see, I told you. And they don't have joint problems. No, they still have joint problems, probably.
No, they're
Fine.
nice.
All right, let's talk about medical management. We can give growth hormone injections, or removal of the tumor if the tumor is present.
Could that help him?
Yeah, it'll at least stop the undersecretion. Yeah.
Doesn't mean to make them grow.
No. She's asking, is it going to make them grow? But if we give them growth hormone supplements, are they going to grow to average height? No. We can never duplicate, guys, what our body does for us. Think of like dialysis. We have to have this big old machine that cleans out our blood, and our small little kidneys do it. And actually the nephrons do it. So it's really hard for us to duplicate some type of machine or some type of medication that really makes you just like your body. Yeah, it doesn't regulate it like your body does. So it does help to some extent. All right, diabetes insipidus. This has nothing to do with blood sugar. Nothing to do with blood sugar. Okay. So if somebody has diabetes insipidus, what should the blood sugar be? I don't know, maybe normal if they're diabetic, or I don't know. It has nothing to do with sugar, okay guys? That's what I want you guys to know. It has to do more with getting rid of a lot of fluids. Anti-diuretic hormone. All right, transient, meaning it comes and goes, or permanent metabolic disorder of the posterior pituitary gland. What hormones are produced by the posterior pituitary gland? ADH and oxytocin. So we're talking about ADH right here. Anti-diuretic hormone. Anti-urinating hormone. So if this hormone is not there, there's nothing that's stopping you from not urinating. So what's going to happen to your fluids? They're gone. You're going to be urinating excessively. There's a deficiency in anti-diuretic hormone. You don't have much ADH, so there's nothing that can actually tell your body to retain the fluid. So you're getting rid of the fluid. Okay? I want you guys to really try to think about that because I would always get confused. It could be primary or secondary, meaning there's something wrong with the actual hormone production, or there's a tumor, and that's what actually is causing the deficiency in ADH. Clinical manifestations. Polyuria. What's polyuria? A lot of, and I'm talking about, guys, a lot. Okay, I forget exactly how many liters a day, but like 20 liters a day. It's a lot of urinating. So what are you doing a lot of? You're drinking a lot of water. Okay. There's a term called osmolarity or osmolality, very similar thing. But anyway, you guys know what that is? Oh, you're thinking of osmosis. Now, osmolality is a test that we do. We usually get the urine, right? And the osmolarity, or the specific gravity, lets us know how many particles are inside the urine. Watch, let me give you an example. If I have a cup of water, right? You guys hear that? There's not a lot of water in there. So if I get a spoon of salt, let's say, and I pour it in there with a little bit of water, the gravity is really high. Meaning, in relationship to how much fluid is inside the container, in relationship to the little spoonful of salt that I just put in, half of it is salt, half of it is water. Do you guys see that? However, if I have diabetes insipidus and I'm urinating a lot, there's a lot of fluid in here. And it's still that same spoon of salt that goes inside. The gravity, or how many particles are inside, is low compared to all that fluid, right? So the specific gravity is low. Does that make sense? The osmolality is low. Does that make sense? That's what I'm referring to with, actually it's specific gravity that I'm really looking for.
The dilution of it?
The dilution of it, that's right, okay? So if somebody has diabetes insipidus, and if you do a urine-specific gravity, okay, I'm urinating a lot. Are there a lot of particles in relationship to the fluid? No, there's a little particles, so it's got a low gravity. Does that make sense? Look up the therapeutic level for the gravity, for the urine gravity. It's in your book.
Does that cause like problems with like your bladder and?
No. It doesn't cause problems with the bladder. It can indicate dehydration. It can indicate a fluid retention. It can indicate a lot of issues like that. In this particular case, we know that we're getting rid of a lot of fluids. The patient's going to be drinking a lot. What's the patient at risk for if they keep getting rid of fluids? Dehydration. Okay. Electrolyte imbalance.
So it's not concentrated.
It's not highly concentrated. It's for this one, guys. Listen. For this one, it's not highly concentrated because you have a lot of water. Okay, a lot of water being excreted. Okay. Now, patient may become severely dehydrated, right? You guys know that now. Patient becomes lethargic, dry skin, poor skin tone because of the dehydration, and the poor fluid status. Constipation. Why constipation? That's right. In the large intestine, folks, water is being reabsorbed. It's forming the stool. There's no water to be absorbed, so there's going to be like, think of dry powder going through your large intestine. You become constipated. It's not, the motility is gone. It's not moving. You develop constipation. Medical management. You can give ADH preparations. In other words, like injections or medication that has ADH. Limit caffeine. This is very important. Limit caffeine due to its diuretic properties, meaning it's going to make you urinate more. It's going to cause uresis, and you don't want that because you already have diabetes insipidus, which has nothing to do with your blood sugar, right? Okay. May I switch the slide? Yes. Before I go to hyperthyroidism, actually, that's it, guys. We're done. We're done with the first disorders. All right. We'll want a little 10-minute break.